Since 2015, Pop Health Podcast has brought to you some of the best minds in healthcare, including leaders from government, not-for-profit, and investor-backed powerhouses, as they share successes, failures, and how our audience can move forward in today's constantly evolving healthcare world. Thank you for joining us for today's episode presented by 24 Hour Home Care. Hello, everyone, and welcome to another episode of Pop Health Podcast. I'm Gavin Ward, host of Pop Health Podcast. In today's episode, I had the opportunity to sit down with Athena Chapman and Elizabeth Evenson, both from Chapman Consulting. The reason I invited Elizabeth and Athena to the show was really, at least initially, because of the recent Year 3 report from the Department of Healthcare Services that shows some of the return on investment of the California Advancing and Innovating Medi-Cal, or CalAIM initiative. This is some of the first data that has come out from the Department of Healthcare Services here in California. And since Chapman has such expertise and works closely with DHCS, we thought they would be great to connect with and learn their thoughts on some of this initial data and positive ROI of the initiative. We also learned in today's episode a little bit about how Chapman initially got started through Athena's background and work, and how she eventually brought Elizabeth back in, and how they now have 12 employees working on a multitude of initiatives here in California with a big focus on the CalAIM and Medi-Cal Transformation initiatives. We hope you enjoyed today's episode. Feel free to check out other episodes of Pop Health Podcast by visiting us on pophealthpodcast.com or checking us out on YouTube or wherever you listen to your shows. Thanks, everybody. Enjoy today's episode. Hello, Athena and Elizabeth. Thanks so much for joining the show today.
Hi. Goodness.
You're absolutely welcome. It's a joy. I've known of Chapman and worked with Chapman informally, I guess, over many years, mostly in Northern California through the CalAIM initiative. It's my first time meeting Athena, as I said hello just a few minutes ago, but I've known Elizabeth and her colleague Donna as well for a couple of years now, and some other colleagues of yours at Chapman. So really appreciate the work that you all have done here in California, and look forward to getting to know you all a little bit better today. And I'm sure our audience is eager to hear about your thoughts on some of the DHS information that we'll talk about a little bit later. So you all might know, we do like to get to know our guests kind of outside the workplace a little bit to start with a fun fact or surprise question. So let's start with Donna. With Elizabeth. We were just talking to Donna off air. She's listening in right now. Elizabeth, can you tell us a fun fact about you, something perhaps outside the workplace?
Yeah, outside the workplace, I have two younger kids, and we love getting outdoors any time of year. We ski and in the winter, and love hiking and camping in the summer.
That's great. For skiing, do you ever go to the Tahoe area, like Tahoe area?
Yeah, we ski at Sugar Bowl, which is the closest resort off Highway 80 to Sacramento, but also real family friendly and is our home away from home in the winter.
That's great. I go skiing about once a year. I'm based in Southern California, but have a friend who has a place up in Tahoe. So we, a group of us from high school, we're still friends 20 plus years later, and we go up once a year in the Tahoe area. So that's a cool connection there with you. And Athena, how about you? A fun fact, something about you that might surprise the audience.
Yeah, thank you. So I also have some teenagers in the house that drive me crazy sometimes. And one of the ways I stay balanced is doing a lot of yoga, actually certified as a yoga teacher, but have found less and less time for that as we've been growing Chapman Consulting, but do find myself frequently going to yoga in order to stay balanced and kind of clear my head from all the things going on in my crazy household and then being busy at work. So really enjoy that. And then also my husband and I own a record store with actual vinyl records in downtown Davis. And so that's something else that we do in our spare time, lots of live music. And my husband runs a record store, but I hang out there occasionally.
That is great. I have a friends not at work, but outside that would love to hear this. So out of curiosity, since you own a record store, are you or your husband, do you play any instruments, any past history as musicians, touring the country, anything like that?
Oh, no, I wish. I tried, but was a failed piano player. So no, we just enjoy listening to music and the community and what it brings to the community. So.
That's great. And you mentioned you host live music then at your, the store is set up in a way that you can, I guess, have audience listen in to live music.
Yeah, there's a stage and a bar with a couple of beer taps. And so we have live music, and there's actually a music festival coming up this weekend, and we'll have rotating folks at our stage is one of the locations throughout town where they have live music.
Oh, that's great. I'm bummed we didn't get this out sooner. By the time this gets released,
It'll be over
yeah.
next year.
All right. So what's the name of we'll let you give a little shout out to your record store. What's the name of it?
Armadillo Music and Records.
All right. That's great. Well, that's really cool. And best of luck this weekend. Hope it's a blast and not too much work this weekend. Awesome. Well, I appreciate you both telling us your story. Folks, I didn't mention Athena is actually the founder. We'll get into that at Chapman. And Elizabeth is vice president at Chapman as well. So let's jump back to you, Elizabeth. And can you give us a little bit? I'm going to shift back over to Athena. Tell us a little bit about your background, Athena, and ultimately what got you to think, hey, I should start a consulting organization.
Yeah, so I got a degree in public policy, a master's in public policy back east, and really have just been interested for a long time in politics and policy. My parents were very interested in politics, always had the news on, were always talking about kind of things that were happening both locally and nationally and even internationally. And so just kind of grew up around thinking about policy and politics and how they interact, with our daily lives and how we kind of think about the use of government in effective ways. My dad worked for the government in parts of his life and just really wanted to try and make a difference. And I, got my policy degree and then got a job with the Centers for Medicare and Medicaid Services out in San Francisco. So that just kind of cemented the health policy part of my interest. And so that's kind of where it all got started. And just have really wanted to see where we can make a positive impact in thinking through how policies impact people's lives. And so I decided to kind of get in, and through government, learned a lot, both at the federal government and the state government. And then that eventually, just led to continued policy development expertise. So that's kind of how it all got started.
Okay. So starting from scratch, well, I'm not sure, for me, I've had the opportunity in my life to think about that in the past, and I was always chicken. I was always like, that's starting my own thing, Mm-hmm. I'm curious, have you done a little bit of consulting outside for a little bit before jumping in full time, and you kind of knew that you can make this work, or did you just jump right in with nothing?
Yeah, I did just jump right in. My husband likes to say that my mother told me I could do anything I wanted to anytime. And I believed it. So I was just working, I worked for the federal government and then the state government, the state Medicaid agency, and then went to work for the Health Plan Association, working with the managed care plans throughout California on commercial products, Medicaid products, ACA exchange products, and all the regulatory and compliance. And really what I found, and the part that I loved, was working on different things and thinking about how to bring people together. Like for instance, working for the health plans, people have a certain perspective about health plans, but we were able to effectively, get them to work collaboratively with provider groups and work collaboratively even with consumer advocates on some key issues, which I just thought was something that doesn't normally happen. If we really start to think about what we're all doing, like especially in the Medi-Cal space, they're really working for the same goals. And so if we can just align around those goals, we won't agree on everything, but there are really areas of alignment. And I just found such, sort of interest and joy. And really when you can get those folks in the room to talk about, well, what are our common goals and how can we put aside maybe some of our differences, but think about how we're stronger together when we advocate for better services, lower costs, better outcomes. That's what everyone's really interested in. And actually that really started, and we'll talk about community supports, but around some work around what are in lieu of services, which is the federal name for community supports, where we really did build a really strong coalition around how to reimburse for those and how to think about implementing them. That was, for lack of a better term, sort of strange bedfellows being brought together. And so I just really saw this opportunity to take that and kind of build on that stakeholder engagement and that knowledge to kind of think about how we, again, influence policy in a positive way by bringing everyone to the table who really, while you may not have fully aligned, goals and objectives, you do have some. And so building on those to really push forward, system change and positive implementation of programs and policies.
Well, that's great. I'm glad we have people who are passionate and capable when it comes to change management, things like that. That is something I have no skill in, and I'm in awe of colleagues at my day job as well as folks like you who are able to make that work. So, when you went in full time into consulting, was that here in the last 10 years, or tell us about the time frame for that?
Yeah, so it's been 7.5 years
Okay.
since we've been out, and it started just me by myself. Just put up a little shingle and got started, and then I was able to bring on some folks the next year, starting with Elizabeth, and was really excited when she was. We had been worked together in a previous job, and was really excited when we were able to bring her over and help continue to build. And now we are at 12 employees as of this week. So we're really continuing to expand and grow. And that's just another thing I really like, is that as we grow, it kind of organically happens, and we bring on just smart people that want to do good work. And, when you own your own firm, you get to, make more of those decisions and kind of, lead the direction and kind of the culture of the firm. And that's been really important to me as we've been growing and thinking about who people is, that we really do emphasize what the culture at Chapman is and what kind of a firm we want to be and the kind of projects that we want to work on.
That's great. And you mentioned you previously worked together. I believe the organization was the California Association of Health Plans. Yes. So I guess Elizabeth was good enough of a colleague. We're like, hey, let's. How can you bring her over? So Elizabeth joined. And how long, Elizabeth, have you been with Chapman?
Been with Chapman for just over 6 years now.
Okay, and the first hire, I probably could have figured that out based on the timeline that Athena had mentioned. Well, that's great. I appreciate you, Athena, giving a little bit of background. I know most of your work is here in California. We're going to jump in a little bit about your area of expertise, and this could be for either of you. So I do know, Athena, you mentioned you have time with both the federal government, state government, the state association. So can you tell us about your expertise, maybe in a little more detail? Either of you are welcome to answer this one.
I can start off, then hand it to Elizabeth. So one of the areas of expertise is really the folks that are eligible for both Medicare and Medicaid. When I was at the federal government, got to be part of some of that cross-sector collaboration, even amongst that big government agency. There's, often silos between the two programs. And so I was lucky to work on some projects where we're really able to look across those two programs and how to better integrate them, and looking at some of the first dual eligible special needs plans. So really on the ground, as folks are really looking at solutions for integrated care for that population. And along with that comes, of course, some of the extra services they need, like long-term services and supports, things like community supports, things that really help people stay in the community. And so we've really developed a lot of expertise over the years, and like watching that, having been part of the policy development and review of some of those original plans, and then just kind of following that through the state government, and then working with the plans and some of their partners as they were implementing a lot of these integrated products. And then also got the opportunity through the Health Plan Association to learn about the commercial side of the insurance world, which was really interesting, and got to be part of the Affordable Care Act development in California, and covered California as it was being designed and implemented. So got to engage with the plans and with Covered California and the other stakeholders, and sort of how does that plan design look? What does it look like to be part of the Covered California as a health plan? And so really got to learn a lot about kind of some of those new and exciting things that were happening as a part of DCA. And so we have that expertise, let's say, across the public program space, and then also know enough about some commercial insurance to help navigate some of those dynamics as well.
Awesome. Before Elizabeth jumps in, just to clarify some of the terminology, we might have folks that are listening in that might be new to healthcare. Mm-hmm. And so I just want to clarify a couple of terms and invite Athena or Elizabeth to correct me if I'm off here. So one of the things you mentioned is like dual eligible. So those are folks with both Medicare and Medicaid, or Medi-Cal here in California. Typically in this, Athena or Elizabeth jump in, if someone's on a special needs plan, my understanding is that typically means that they have higher medical needs, and might while also being Medicare and Medi-Cal. Am I correct, or do they not need both to qualify for a special need plan?
So there's a lot of different kinds of special needs plans, but the ones that I was referring to are the dual eligible special needs plans, which are specifically for anyone who is a dual eligible. So that qualifies them for enrollment in that plan. Yeah. And then there's other ones for institutional care, chronic care, to really help kind of hone in on specific populations where you really need to design a network that's, specific to a certain population.
Awesome. Thank you. And you also referenced your expertise with commercial insurance. So that would be typically your private or employer-based insurances that many of us have, like I have in my day job, for example. So again, I know for you and Elizabeth, these are normal terms, and for, healthcare colleagues, but I do know there's some folks out there who are relatively new. So just wanted to clarify. I know you wanted to pass it off to Elizabeth as well. Was there anything else, Athena, before we let Elizabeth jump in?
No, please go ahead, Elizabeth.
Yeah, thanks. So in addition to what Athena mentioned with working in the Medicare and commercial space, we do have deep expertise in Medi-Cal policy development. We've worked with county agencies as well as plans, and have been working with a lot of community-based organizations as well to kind of help them understand and navigate the insurance Medi-Cal space and before CalAIM even, and now especially with the focus on bringing more organizations in to deliver non-traditional Medi-Cal benefits. We've been helping a lot of community-based organizations out.
That's great. I know you have some of those organizations listed on your website, so it was cool to see. I've been, as I mentioned, had the opportunity to be at some of the events and groups that you help facilitate, Elizabeth. I mentioned your colleague Donna as well. So that is great. Let's jump into CalAIM, or California Advancing Innovating Medi-Cal. You also might hear folks out there in the audience might hear the state use the term Medi-Cal Transformation a lot as well. And there's a lot of overlap there. I'm still learning exactly how to phrase those together. But Elizabeth, can you share with us a little bit about the work you guys have done there at Chapman? I would say particularly since 2022. I know you're probably doing CalAIM work before 2022, before it launched, but maybe share with us some of the work, especially maybe in Northern California, that you guys have done with the community there.
Yeah, so thanks. We are kind of got started in the CalAIM space. We were selected by the Department of Healthcare Services to be one of the 25 organizations that are facilitating these collaborative planning and implementation work groups. We facilitate two of those, one in San Francisco and one in Santa Clara, and they bring together the managed care plans in those counties, community-based organizations, the local government, and other additional stakeholders to figure out how to deliver these new non-traditional kind of medical benefits to improve the health and well-being of some of the state's most vulnerable Medi-Cal beneficiaries. And in addition to those collaboratives, we're also helping some community-based organizations, like I mentioned, really understand the changing market dynamics and how to contract with the managed care plans and kind of what systems they need to get set up for success there. And we we've been facilitating local or learning collaboratives on the DSNP implementation with local plans, have been helping a plan to operationalize the Population Health Management Initiative, all of these kind of across the board, really getting our fingers deep into the policy and operationalization.
Yeah.
Of CalAIM and Medi-Cal Transformation.
Awesome. You mentioned the acronym DSNP. I believe those are the dual eligible special needs plans that we talked about. I'm just helping myself learn. Correct?
Yeah.
Did you get that right?
Yeah.
Okay. Awesome. Well, thank you so much. Well, yeah, I appreciate you sharing a lot of the work there, especially in Santa Clara and San Francisco counties, two very populous places. I know in Santa Clara you have Anthem and Santa Clara Family Health Plan as the plan partners.
And Kaiser.
And Kaiser, forgive me.
Yeah.
Kaiser's everywhere. I should know better. And then in San Francisco, I believe you have San Francisco Health Plan, Anthem, and Kaiser, as well as your plan partners. Did I get that right?
That's correct. Yeah.
Okay. Awesome. This is kind of off the cuff, but you've been there for a few years now. I think since 2022, technically facilitating these roundtables or path collaboratives or
different various events. For you in those 3 years, or Athena, feel free to jump in. Like, what has been some of the highlights or something that you look back and you tell your kids, I love my job, or we accomplished X in these three so far? I know there's more to come, but curious what stood out to either of you.
It's just been so rewarding hearing the success stories of some of these smaller community-based organizations that have never been traditional providers of Medi-Cal benefits, really getting a chance to work more closely with populations who they're already connected with, like the first fives, working with children, or kind of adult day healthcare centers, really being able to take their deep expertise and knowledge about the communities that they serve and helping individuals more holistically get a better sense or a better handle on their health and taking people who may be chronically homeless or unhoused, helping them find a primary care provider for the first time, get to their first primary care appointment, understand, why some of the habits that they might currently have really have an impact on their health, and how to move from, being chronically unhoused to getting that support to establishing residency, getting a job. It's, also for individuals who are leaving the justice system, formerly incarcerated organizations who are able to take advantage of these new Medi-Cal benefits and billing the managed care plans to get more funding to help more people really wrap around them in a holistic way and improve their health and well-being.
Yeah, that's awesome. And I've heard that from others as well, just seeing things come to place that may not be possible in the past. How about you, Athena? Anything to add as well? I know you've been a little bit more from a leadership lens versus on the ground, but curious what you've seen.
Yeah, no, I would agree with what Elizabeth said, sort of seeing for years we've been at the policy level. And so it's nice to get down and see things actually at the more implementation operational level and watch those connections being made. But I think what's most interesting to me, and having watched it grown over the last several years, is the collaboration. Again, going back to one of the things I love about this is being able to see nobody's required to come to these meetings, right? But they do, and we continue to grow. And as new people come into organizations, they come and they find it to be a great resource and a way to make connections. There's so much value, I think, in just the face-to-face connection and realizing where, they have, they can work together, and it really does help build those relationships. So much of healthcare really is about those relationships and making sure, that things can get connected. And so, there's been participation in work groups that people have put in extra time, and we know these are all very busy people, but the fact that they see the value in this for themselves, for their organizations, for the members they work with, no matter what hat they wear, that there really has been just an amazing amount of collaboration at the local level. And so to then see that happening, I know we'll talk about it a little bit later, but the data is coming out that these things are actually getting out into, to people and being, being utilized, and that's been the goal. So I think that's just been really amazing to watch.
That's awesome. And yeah, I'm definitely eager to talk about the data here in just a second. Before we jump into what we've seen so far and maybe what DHCS is saying about return on investment, things like that, I want to understand what you guys are looking at for the latter half of the year into 2026. Can you share a little bit about what you're looking forward to or looking forward to do in the next 6 months plus?
Elizabeth?
Well, we're continuing the collaboratives through the end of 2026. So getting, staying in the communities and helping more individuals and organizations realize that these benefits and services are out there. What else are we looking forward to? That is a great question. They hadn't really thought about too much.
No problem.
Yeah. I mean, I think just looking forward to, like I said, getting down that next layer, right? So now we've been talking about, as you mentioned, we've been working with clients and, thinking about CalAIM since, before before 2020, when that was starting to be developed as a waiver and concepts, and sort of preparing folks to think about how this could be something that could help them, help their organizations and the people that they serve. And so to watch it, these things all move slowly, slower than most people want, but that we've kind of hit this tipping point now where we know the services are getting out. We know that people are collaborating and integrating care. And so I think really looking excited for opportunities for us to get down the next layer, right, to where implementation's happening and toolkits and resources, and then just continuing to find out where those gaps are, where people, because, as you mentioned, with all of our acronyms, the way we talk, we're so in it day to day, we can't imagine that nobody else knows what this is. But we do know, there's people at county health and human services agencies that don't know a lot about this.
Yes.
And all these people where you just think, wow, there's such an opportunity here. And now that it's actually up and going, there's more to show them as to why they should be paying attention and how it could be important to the people that they're serving.
Yeah, no, well said. It's amazing that we would just assume, right? You mentioned county entities, even entities that serve the Medi-Cal population are in healthcare, aren't fully aware of the CalAIM initiative because everyone is so focused on their day-to-day tasks, which within good reason. So I'm surprised even 3 years later, we go to hospitals and we meet a case manager who's been there for 10 years and oh, Medi-Cal can fund. The good news is most case managers in that scenario that are in my world do know now, but not all, right? Yeah. So really good point. So let's jump into the ROI, right? So I think I'll jump over to Athena on this one, but Elizabeth, feel free to jump in. CalAIM, I think when I first heard about the California Advancing and Innovating Medi-Cal initiative, I assumed that the health plans were getting a bunch of money ongoing from DHCS, or there was additional funds that were not just a one-off to get it started. But that's not the case, right? There might be, well, let me just ask you, Athena, how was this initiative, the CalAIM initiative that started in 2022, how was it initially funded and how is it expected to continue?
Yeah, it's a great question. So without getting too wonky into the mechanics of all of the waivers and everything that, I know most people don't follow, but it really was thought of in a couple separate buckets. So one of them was the enhanced care management bucket, which is a set of services that has become part of the Medi-Cal managed care benefit. So they actually are building that into the rates, and how Medi-Cal rates are built is extremely complicated, and we don't need to get in all of that. But the idea is that it does create an incentive for them to use these services in order to, prevent more costly care or unnecessary care and improve outcomes, right? And so then it's built into their rates in order to provide these services and really manage the care in a way that thinks outside of just the traditional doctor's visit or hospital stay. And then there's community supports, which have their own designation in federal law, as I mentioned earlier, referred to as in lieu of services, and they're really supposed to be in lieu of something more expensive. So yes, you can pay for this home modification because otherwise this person would have to stay in a skilled nursing facility where they don't really need to be, but now we can move them home. And that, of course, is better for them and then does have long-term cost savings to the system. And those, per federal statute, are not mandatory for the health plans to provide, nor for the beneficiary to accept. And so they're just a slightly different way of thinking about it. But I think over time, and we can talk about the data that just came out about community supports, is that they are supposed to have better outcomes and reduce costs. And we're starting to see some of that. So those are funded in a slightly different manner. But the idea is over time, you show that and then you can build it into the overall benefit over time, I think is the state's intention. Of course, lots of moving pieces there, but I think it's really meant to be part, people talk a lot about CalAIM as like a 5-year waiver program. And there's been previous waiver programs where they've done more like a pilot, like they had a whole person care pilot in the previous waiver, which was a pilot. It had an end date and a lot of those things transitioned. But really, they're thinking about this as Medi-Cal Transformation. This is meant to be ongoing. These services don't end when this waiver ends. It's just how do they build it into that going forward. And so I think that's really an important distinction. And I've been trying to get people to talk more about Medi-Cal Transformation rather than CalAIM. And I know, others have as well, because then people don't think, well, the 5 years is almost up. Why bother getting into this now? Because I'm going to get up and running and then that funding source is going to go away. And I think the intention is that it is a, ongoing part of the Medi-Cal benefit.
Yeah, definitely. I know there's other statewide programs that are on these 5-year waivers as well that get renewed, or
Mhm.
there's funding provided in different ways. So I know the
I heard,
regions. Go ahead,
yeah, when
Elizabeth.
we heard DHCS as well recently mention or reiterate that while these originated from a 5-year waiver, they are written into the managed care plan contracts. And so it is really envisioned that while the state got a kind of a big bolus, I think this is what you were referring to earlier, of funding to help organizations get set up to be able to have the infrastructure in place to be able to build the plans, to establish those contracts with the plans, to really be able to be HIPAA compliant and do all the things that they need to do to be able to provide benefits and services to Medi-Cal beneficiaries. They really are intended to be a part of the Medi-Cal benefit in perpetuity.
Gotcha. And I know that's a great point, Elizabeth. I know, Athena, you mentioned that with the ECM, for example, the goal is for that to actually be a benefit. And I think we didn't touch on this, but I learned that, like, community supports, for example, and you touched on this, Athena, it's not a benefit of the plan, right? It might be in the future. Not more, we don't know, but the ECM component, or enhanced care management. I appreciate you saying enhanced care management, by the way, instead of ECM. I just caught myself.
I'm trying.
I said ECM, but can you clarify on the ECM component? Is the decision already made that it's going to be or is a benefit? Forgive me for not understanding that part.
Yeah, I think as Elizabeth mentioned, it's part of the Medi-Cal managed care contract. It's part of the rates. Now, we don't know. We can't read the tea leaves of exactly what will happen in the future, but I think that was the intent, was to build it in as any other benefit in the Medi-Cal program.
Got it. Sorry, Elizabeth. Sounds like maybe I could ask you that one. But thank you, Athena, for covering that. Okay, cool. So I want to jump back to the data as we get towards the end of the episode today. DHCS put out its year 3 annual report that was labeled, I believe technically they revealed into some information in April. I saw an email in June mentioning it was out, so I might have missed something in between. But they did go over some of the ROI, and I wanted to ask Athena and Elizabeth, feel free to jump in. Can you give some of the highlights from that report?
Yeah, I mean, I think the key takeaway is it's good news, right? After all this, policy development, implementation, collaboratives, work at the, state, local, actual point of service, the things are actually rolling out and people are getting services and it's starting to work. So I think that's the key takeaway. I think, there's really, you talk about ROI, and as I've been thinking about things, recently and talking with folks, is that, we know with, what's happening in state budget and otherwise that there's going to be a tightening of the belt no matter what happens, in specifics and policy changes. We do know for at least the next several years, there's going to be really important to think about how do we utilize these resources effectively, right? If we don't want to see benefit cuts and we don't want to see other things, to really reduce redundancy and think about how to be more effective in the utilization of those dollars. And this is a great example of that, right? It's showing that there's ROI. And so I think just continuing to sort of, evaluate that. I think it's really difficult to show ROI on something that didn't happen, right? So I think it's great that they found a way to look at it and quantify it and really show, because I think that's really one of the challenges with something like this, is that it's hard to, say something that didn't happen, right? Because you can't really necessarily always prove that, right? But we are seeing that in the data that's coming out. I think there's also a lot of opportunity, right? There's over 14 million people on Medi-Cal, a third of the population is on Medi-Cal, and I think they had like 250,000 or so people have gotten community supports. Now, not every Medi-Cal member will need it, but more than that for sure, right? Since we know there's 14 plus million people on. So I just think, wow, there's so much more opportunity here to continue to make the system more integrated and more efficient and better for members' outcomes and also long-term, spending. So I think those are some of the things that I thought was really interesting coming out of this report. And like I said, I was really glad to see them being able to put it in a quantifiable way, because I know that's not an easy task.
Definitely not. And you mentioned quantifying something that didn't happen. So just to clarify, what you mean by that, and correct me if I'm wrong, is for example, we prevented a hospitalization.
Right.
Correct. Or in lieu, by spending X on this preventative service, therefore Y didn't happen. And we might look at another group that didn't receive services and we compare it right? And the group that didn't receive services had a higher likelihood of being hospitalized. So I think that's what you meant. I see you nodding. Okay.
Yeah, that's what I meant. But sometimes I think it's hard for people to understand that, and some of the, big provider organizations or, some of the bigger health plans looking at like, do I really want to spend my money investing in this? Or does it make sense to contract with these providers, because it's hard to say, will it have the impact? And how do you know if, you necessarily did prevent a hospitalization? That's not always easy to say 100%. But I think, like you said, there's good indicators and proxies and ways to kind of look at that. And so I'm just glad they were able to put it out in a way that the public can consume, that policymakers can consume, right? So that we know, okay, this is moving in the right direction on kind of all fronts.
Yeah, no, that's great. I was actually at a meeting with a health plan, I'll leave nameless, recently, and their executive team was making decisions on, do we continue to invest in community supports? Because, we're spending millions, right, on community supports.
Mm-hmm.
And initially, they didn't see the ROI. But once they actually later on saw ROI and they heard from the community, they heard from medical providers, they actually changed their mind and decided, this is very recent. So some of you that are listening, or even you may know who I'm talking about. So yeah, it's great. I know, Elizabeth, you're on the ground in your 2 counties that you're seeing. Any other feedback related to the same question on ROI or what you anticipate you're moving forward?
Yeah, I think the report lays the data out in a really interesting way as you're thinking about it, right? Like you might see they tie the housing trio to like a decrease in emergency room visits and a decrease in inpatient visit or inpatient stays, but an increase in outpatient services, an increase in access to behavioral health services, which, on the face of it, if you're looking at it and you think, oh no, like it, that means that it was more expensive in these other ways, but it just means that people are really getting access to the care that they need and in outpatient rather than inpatient, and getting ahead of some of the things that would land them in the emergency department in the first place. It's really interesting to take a look at and really great to see.
Yeah. So just to paraphrase, an increased expense in outpatient behavioral health in exchange for a decrease in inpatient stays is a big positive, even though there's that increased outpatient behavioral expense. So luckily we have smart people like you where you get that, because I think some people just hear the higher expense sometimes, like I mentioned with the board, who they're wise as well, and they realized, hey, we need to take a second look at this. So yeah, this has been great. You guys have obviously done great work in your 2 counties and beyond, because I know Chapman's done a lot of work, not just in San Francisco and Santa Clara counties, and that you guys aren't just CalAIM leaders and experts, but your policy, Medi-Cal, and probably can help with a lot of different initiatives. So before I let you 2 go, I want to give you another opportunity. Is there anything about Chapman or the Medi-Cal Transformation umbrella that we didn't touch on today that you think our audience should be aware of?
Yeah, I think that we just really are interested in system transformation. And like I said, really getting down to that next level of like, not just thinking about the policy, but thinking about the implementation, really thinking strategically, over time. Like I said, we were talking with clients about CalAIM, in 2019, put a little pause during 2020 because many things were paused during that time, But just really thinking about like what's coming, what's to be expected in a time when we've got kind of a lot of question marks about what might be happening in healthcare. Just thinking about what are the things that we know, what are the things we should anticipate, and how do we just continue to think about making the system work better. I think now more than ever, really finding ways to develop those partnerships, to reduce redundancy, to align, financial incentives across the system, to better align member outcomes across the system so that they're getting all these different touches, but those are better aligned and coordinated. There's just so much opportunity, and now is really the time, because as I mentioned, we know that belts are going to be tightening no matter what happens. And so really, I think it is the moment, and that we've really in California laid a lot of groundwork for that with these programs and been really at the front. And so just really interested to see how some of these things may translate into other states that are interested in, exploring some of the good and positive outcomes that we're starting to see in California, and how we can continue to grow that both here and in other states.
Awesome. Elizabeth, anything for you to add?
I'm just really excited to continue to see how organizations come together to improve the healthcare for many of California's most vulnerable populations, like busting down, I don't love this term, but getting people out of their silos, getting organizations more connected to each other, really building that community and seeing healthier folks as a result of that.
Awesome. Really quickly, if folks want to join one of your collaboratives in your 2 counties that you're in today for Medi-Cal Transformation or the CalAIM initiative, so for Santa Clara and San Francisco folks that are listening or watching, how can they get connected and more information on those 2 collaboratives, Elizabeth?
Yeah, we have a link on our website, chapmanconsult.com, to all of our collaborative resources. And I believe we also link to the state's registration page for folks to get registered through the state as well. Always love to have more folks at the table. And so if you're interested in joining Gavin and myself and sometimes Athena at a collaborative meeting, feel free to register.
Awesome. Well, I really appreciate Elizabeth for helping bring this episode together, including bringing in Athena, who I hadn't met before and who obviously leads the organization. So thank you both for making time today on relatively short notice due to I should have done a better job planning for this episode, but thank you for turning it around so quickly. I really appreciate you both. And we'll see you probably in one of your 2 collaboratives.
Looking forward to it. Thank you so much.
Thanks everyone for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.